All right, I see people are joining, so we're just gonna give it about a minute before we get started to let people get in. John, do you want to do me a favor?
Certainly.
Do you want to do our routine? Can you type in the chat the Connect email and our website, please?
Yes.
Because I was going to have you do it anyway. All right, well, I think we'll get started. Some people typically roll in a minute or two after 7, so we are going to get started. Welcome, everybody, to this week's virtual meetup hosted by the Epilepsy Foundation of Wisconsin. My name is Alicia Thompson, and I'm the program manager here at the foundation, so welcome. With us tonight, we have John. John, if you just want to wave. Okay. John Mirasolo, he also works at the foundation. Do you want to say something, John? You can. Sorry, I know you're typing. My bad.
That's right.
Okay.
Hi, everybody. My name is John. Work with Alicia. Generally, I work with communications, client support, and social media.
Wonderful. Thanks, John. Tonight's topic, we are talking pediatrics, attention, and cognition, not just seizures. And we have Kristen Seaborg on with us tonight. She is a pediatric neurologist with the University of Wisconsin Hospital and Clinics. So welcome, Kristen. Thank you so much for being here.
Thank you.
Before I turn it over to her, just a couple housekeeping things. So we are recording this. Some of you may have already heard that. We're recording this. It can be found on our website, which John is typing in the chat within the next couple days or by early next week. So you can, if you want to look back on it, you can watch it, or you can refer other people to the video as well. Also, if you are an attendee on this call, please know that you are muted and your videos are off. In order to ask questions, which we do encourage, so please ask questions. You can use the Q&A button that's on your screen, or you can use the chat. Either works fine. And John and I will be monitoring those questions. Feel free to ask them throughout Kristen's presentation, or you can wait till the end. That's fine as well. But we'll do all the questions at the end. And then just for sake of time, please know that we might not be able to get to all of them. John did type an email in the chat section where you can send questions to if you're maybe not comfortable asking on this call, or you think of something after the fact. Please use that connect@epilepsywisconsin.org email. I believe that is all. So Kristen, I'm going to hand it over to you and you can share your screen and we'll start.
All right.
Thank you.
Okay, let me know if this works.
Okay.
I think it should. We'll see though, right? All right. Oh goodness, it's giving me privacy notifications because we're on Zoom. Forgive me.
Oh.
I should have thought about that first. Or I might just ask you, Alicia, to share the slides I gave you. Is that all right?
Sure. Yep.
Oh, that's annoying.
Yes. Let me open it up. Hey, that's
what
why we.
That's why I sent you back up. Okay.
Yep.
Sorry about that.
No.
You see
That's
it?
okay. Yep. I'm gonna hit share. Can you see my screen?
Yes, now
Okay.
I can. All right.
So let
Do you
me
mind yeah.
put it in full view really quick. Good.
That's great. Thanks.
Okay. You'll just have to tell me when you want me to go to the next slide.
Sure. Okay. Sorry about that.
No.
All right. So, hi. I'm Kristen Seaborg. I'm one of the pediatric neurologists at UW. And today we're going to talk about not just epilepsy, but the effects it can have on attention and cognition, and kind of all the reasons why that can happen for kids with epilepsy. Well, this talk is focused on children with epilepsy. A lot of these things also occur or happen in adults. So, well, we'll talk mostly about kids. There's a lot of corollary in the adult population as well. Finally, here I put my email address. If you have any questions that we weren't able to answer, or there are things I can help you with, please don't hesitate to email me. Alicia, do you mind hitting the next one? Okay, so if you guys are parents of a person with epilepsy or have epilepsy yourself, you know that children with epilepsy, it's not just seizures. Kids are at also risk of having trouble that would, or excuse me, certain disorders that would contribute to their trouble in school or any difficulty with cognition or learning. So kids with epilepsy are at increased risk of ADD or ADHD, increased risk of cognitive disabilities or learning disabilities. Kids are at increased risk of mood disorders, so depression or anxiety. Sleep disorders are actually super common in people with epilepsy, and medication side effects. The things that we use to treat epilepsy often come along with side effects. A lot of these things will affect sometimes attention, cognition, or ability to kind of maintain a normal school day and feel okay about it. Next, please. Thank you. So I'm just going to go through these one by one. Feel free to put a message in the chat or ask a question if you have any questions. So ADD and ADHD. I'm a former pediatrician. As a pediatrician, I often was asked, what's the difference between ADD and ADHD? The short answer is not much as far as how we treat them, which we treat them the very same way, we diagnose them the very same way. Kids with ADD tend to be the daydreamers, the people that have trouble maintaining focus on one task, but they're not really hyperactive. The kids with ADHD tend to be the kids that are so busy and so active that they have a hard time sitting and focusing on one thing. So we know that children and adults with epilepsy have almost 3 times the risk for ADD or ADHD. Also, it's been found that if ADD or ADHD go untreated in children into adulthood, it can actually have more negative impact on their quality of life than just epilepsy itself. ADD and ADHD, so some of the cardinal features you'll notice, they're characterized by inattention, easily distracted, the kids that are always on the go or driven by a motor, just moving from one thing to the next. Sometimes children they just have trouble finishing their projects or they have trouble turning in their homework. The way I was taught to think about ADD and ADHD as a provider was, way back when we were cavemen, we had to focus on the squirrel over there and the predator over there and the fact that there was a food source there. So we were paying attention to everything. Now we have to sit in rows in school and maintain focus on just one thing, and it's a lot harder for a lot of us. So it's not a negative thing or a bad thing, but in the environment that we live, ADD and ADHD can be difficult for a child or an adult who lives with it. Furthermore, in order to diagnose ADD or ADHD, kids have to have symptoms in 2 or 3 of these environments that we screen them in. So often you'll hear, oh, well, actually, he does really, really well at home, but at school, he can't focus. That doesn't necessarily mean that they have ADD or ADHD, or they're horrible at school. They're really having a hard time, but, or excuse me, they're horrible at home and they're having a hard time, but at school, they can completely focus on the task. Same thing. It has to be kind of universal across all spectrums. Mind hitting the next slide? And to diagnose ADD and ADHD, actually a variety of providers can help you with this. Sometimes daycare or school or childcare providers are the first people to raise concerns. But then if you bring this to the attention of your pediatrician, your primary care provider, if you have a patient with epilepsy and they're already in the neuropsychologist's care, a neuropsychologist can address this very effectively. Your neurologist can screen for signs and symptoms of ADHD. Treatment for ADD or ADHD, if it's very mild, especially if kids are younger or early school age, you can do some behavioral interventions that will help them to focus, especially when they're in school. And actually in adulthood, people that have grown up with ADD or ADHD sometimes, kind of self-select for their career or their job or what they're going to do in life. I've heard it said that a lot of police officers have ADD or ADHD because they don't have to sit at a desk all day. They can move from one task to another. I've heard the same thing about physicians. We don't usually sit and do one thing all day except for the charts. We can move from one task to the other quickly. However, there are also a variety of very, very effective medications for ADHD and ADD. Most of them are stimulants, but there are some non-stimulant alternatives as well. Next slide. Thank you. So moving on to the next thing that we commonly see in people with epilepsy, cognitive disability or learning disabilities. They're not the same thing, but kind of sometimes can be thought of in the same way of how they affect people with epilepsy. Cognitive function can be affected in people with epilepsy for a variety of reasons. So first of all, genetics. completely separate whether or not a person has epilepsy, their cognitive function is probably a little bit, at least partially related to the cognitive function of their parents. So if your parents are an astrophysicist and a nuclear scientist, your chance as a child of really having some really good brain and thinking is pretty high. If your parents tended to struggle in school, your genetic predisposition might be to struggle in school a little bit more as well. For kids with epilepsy, the seizure type sometimes has an impact on their cognitive function. So kids with generalized seizures over years actually tend to have fewer cognitive changes than kids with just focal seizures. And the seizure frequency, kids that have one seizure every 6 months do not tend to have as many difficulty or as many cognitive trouble than kids that have really, really frequent and really common seizures. I'll talk about in a second, but the anti-seizure medications we choose to treat epilepsy really can affect cognition in the patients with epilepsy. Usually that's a transient side effect because a lot of these meds are associated with sometimes just cognitive slowing or significant sedation, and that can be manifest as looking like some cognitive trouble. And then there's some genetic diseases or genetic variants that lead to epilepsy. PCDH19, CDKL5, these are some of the genes that we found in the last 10 or 20 years that lead to seizures. And those specific genetic variants are also associated with cognitive disability. Children that have epilepsy because they were born with a difference in their brain are on the whole spectrum more likely to have some cognitive trouble. Or children that have had epilepsy for 10 years, 15 years, 20 years, or had an onset of epilepsy early in life that persisted may have some more difficulty with learning and cognition. Next slide, please. All this being said, it's important to note that a recent study done in 2008 of 750 children with epilepsy, only 75% of these participants had normal cognition. As a provider, I worry sometimes that there's a correlation in a lot of providers' brains with epilepsy and cognitive disability, but it's important to remember that 3/4 of people with epilepsy have no difference in their cognitive function than the normal or the regular, not the regular, the rest of the population. Of the 25% that do have some cognitive trouble, there's a really wide range of kind of dysfunction or disability there too. Some people with some trouble with cognition, actually you would never pick up in a classroom. And as you know, some patients with epilepsy do have significant cognitive disability. And I kind of mentioned all of these in the last slide, but some of the things that have been found to correlate with more or less trouble with cognition are the children that have epilepsy onset very early in life or during their early developing years tend to have more cognitive dysfunction. Children that are born with a structural brain abnormality or something different about their brain tend to have a harder time with cognition. Children that have remission, years or months or whatever duration of time without seizures, tend to do better with their ability to learn. And then the anti-seizure medication choices can affect kind of their day-to-day ability to pay attention and learn. So all of these are correlated with cognition. And then chronic seizures. The effects of chronic seizures on brain over years can really make a difference on a person's ability to learn throughout their lifetime. So the duration of the seizures, the frequency of the seizures, and what time of life that a person has the seizures. A child, when their brain is developing early in life, if they have recurrent, repetitive seizures, they might have more trouble learning than a child that has fewer seizures, but later in their life when their brain isn't developing and changing and learning as much. Can you do next slide? And then in addition to just difficulty with learning at baseline, over the years, as a patient has epilepsy, there can be cognitive changes, specifically in patients with focal onset seizures, especially with temporal lobe onset seizures. As those seizures persist throughout time, it can affect a person's ability to focus and long-term memory or ability to actually store short-term memory and use it very quickly again. And then it's, from a neurologist perspective, it's interesting to see that the area of the onset of focal seizures, if they're only starting from one part of the brain, can actually affect different parts of cognition. Excuse me. So seizures, for instance, that start in the language area of the brain, which is the left temporal lobe, that might, over years, if you're having repetitive seizures that start in that area, can affect your language function over the years. seizures that start in the visual area don't usually lead to permanent visual changes, but they can start with a visual aura, like that's a sign that the seizure is beginning there. And then seizures, I actually didn't put this on the slide, but seizures that start in the frontal lobe, which is where we have kind of executive function and our ability to think through a task and do multiple steps of the task. If that's where your seizure focuses, sometimes those children have harder times with the executive function, things that we need to do throughout the day. Your next slide. And then in addition to kind of what kids are already dealing with seizures and some of their cognition struggles, medications can lead to side effects as well. They can affect their cognitive function while they're in school or on a day-to-day basis. So the way almost all anti-seizure medications work is they calm down the electrical activity in the brain so that we don't have too much electrical activity that would cause or is part of a seizure. So while these medications are working to kind of quell the electrical activity, they also have the side effect of sedation. Some of the older medications like phenytoin, valproic acid, or phenobarbital are not only associated with some sedation and some changes in cognition while you're taking them, but if a pregnant mom takes these medications, it can actually affect the cognition of the baby. They're doing more and more research to find the medications that are associated with side effects, but these are some of the ones that as an epileptologist or a seizure doctor, we try to avoid in a pregnant mom. Some of the newer medications, if any of your children were on things like Topamax or zonisamide, you might have heard of the kind of nickname for Topamax is Dopamax. It makes a lot of people feel dopey, like they have trouble with short-term memory or trouble with rapid recall. So these are important side effects to know, because if that's happening to you or to your child, then that's a reasonable reason to come off that medication and try something different. Do the next slide. Then there's a lot of, especially some of the newer medications that are associated with significant sedation. A sedated child can look like they're having trouble understanding or really could have a hard time focusing in school because they're just simply so tired. So this is by no means an exhaustive list, but some of the medications associated with sedation are clobazam or trade name Onfi. The cannabinoids, or trade name is Epidiolex now, but a lot of people are using cannabinoids from other places over the counter. Clonazepam is used sometimes as a seizure rescue, sometimes as a short-term medication, or sometimes as something kids take every day that can be associated with sedation. Rufinamide is something we don't use as much, but is also associated with significant sedation. And every medication, as you know, affects everybody differently. So if you're seeing significant sedation with the medication, then maybe it's time to kind of think about if this is the right thing for you or your child and to go from there. Do next. So we know a child with epilepsy is increased risk for ADHD, increased risk of cognitive difficulty, but there's all this other stuff that comes along with epilepsy that isn't necessarily intuitive. It's not something that you think about when you get a diagnosis of epilepsy necessarily, but as you learn more and more, you might notice that there's some strong associations. So mood disorders are super common in patients with epilepsy, specifically depression or anxiety. And unfortunately, suicidality, there's increased risk of suicidal thoughts in patients with epilepsy, and it can be a side effect of some of the medications. So these are important things to look for and watch for. So while there's a 10% incidence of depression in the general population, it's of depression or anxiety, so it's significantly higher. Also important to know is that depression and epilepsy are kind of interrelated. If you have poorly treated or subclinically treated depression, it can actually make your seizures worse for reasons that are entirely clear to us, but perhaps because it affects your ability to sleep, because we all know stress makes seizures a little bit worse, but things like that. And vice versa, if your epilepsy is poorly treated, or if you have current seizures, that can affect your mood. It can affect your quality of life. So those are all kind of intermingled and related. Thank you. And just important to know, some of the presenting symptoms for mood disorders, especially depression and anxiety, actually don't look like mood disorders at first. So the patients can come to their provider and say, you know what, I'm tired all the time. I can't focus. I have a hard time remembering things. These various things can be depression, or they can be anxiety. Those are two very treatable things. So it's important to kind of screen your patients or your children or yourself for these things, because mood disorders are very treatable. And I think we just talked about mood disorders can exacerbate epilepsy and vice versa. In addition, there's some other things that you might not really think about when you think about epilepsy and cognition, but it's definitely related. So sleep disorders, things like sleep apnea, things like disrupted sleep, seizures during sleep. Sleep disorders are super common in patients with epilepsy, definitely in children with epilepsy. And actually, I think there's at least a 2 or 3 times incidence of sleep disorders in patients with epilepsy compared to the general population. Just like mood disorders and epilepsy, there's actually this really tightly bound reciprocal relationship between sleep disorders and epilepsy. So patients with epilepsy have a higher incidence of disrupted sleep, and subsequently the sleep disruption or the sleep deprivation can put patients at epilepsy at increased risk of seizures, excuse me. So it's important to kind of pay attention to 2 of these things because they definitely impact one another. And just an important point, failure to recognize and treat sleep disturbances can also lead to worsening of cognitive function. So think of how you function on a day after you've slept really poorly the night before. It's hard to focus, it's hard to pay attention, it's hard to perform a task very quickly and very clearly. Also, like we just talked about before, increased seizure frequency can happen if you're sleeping poorly. It can happen if you are having any other comorbid disorders. So it's all definitely something to screen for. Real quick about sleep disorders, some of the things you might notice in a patient with epilepsy, or really anybody with a sleep disorder, would be loud snoring at night, stopping breathing at night, gasping, like waking up, that type of things. Or kids actually could complain of a headache in the morning or a dry mouth in the morning, which could be a sign that they had sleep apnea. Also just persistent or pervasive fatigue during the day, not related to medications, not related to seizures, sometimes can be suggestive of a sleep disorder. Patients, especially those on sedating medications with epilepsy, can have something that we call central sleep apnea, where actually your brain doesn't tell your body to breathe because there's a little bit of a disconnect there. It's not super common, but it is more common in patients with epilepsy. So another thing that's very treatable and important to screen for, because we can help decrease the incidence of seizures and improve cognition overall. You do the next slide. So I just went through, probably too quickly, but 1,000 different things that can happen in a child with epilepsy that's not necessarily the seizures, which is what everybody thinks about, but all these comorbid disorders that can make epilepsy worse or can be a side effect of the epilepsy. So ADHD, cognitive disability, cognitive changes over time, some of the medication side effects, any mood disorders, any sleep disorders, they all go hand in hand with children with seizures. So if you guys are like me, when you sit at a talk like this and you listen to the giant cohort of coexisting conditions, it's a little bit overwhelming. So what can I do? If you're a parent or a patient, really kind of, I think knowledge is power. The first step is being aware of all these things that can be part of the whole epilepsy spectrum, but not actually seizures themselves. So paying attention to how you're sleeping, how you're feeling, how the medication, how you feel with your new medication, or how things have changed as you've upped your increase or upped your dose of medication. And also paying attention to seizure frequency and how that relates to everything else that's going on. If you're a parent, don't hesitate to advocate. As a pediatrician, watching the parents advocate their child to have an IEP or a 504 at school, talking to the pediatrician, the neurologist specifically about your concerns, and bringing it up with school personnel, and not being afraid to say, my child needs this in order to succeed. These are the things, are the ways that you can help your kids do well in school and not be frustrated with school, especially if they're struggling for any reason. And just the obvious, but everybody knows, if we maintain medication compliance, if we encourage the kids to take their medications when directed and avoid missing medications, fewer seizures means better cognition, better focus, and hopefully overall just feeling better about life. And don't hesitate to talk to your neurologist about any concerns. If you feel like things aren't going that well, don't sit back and wait for them to get worse. It's always okay to bring something up. The next. And then this seems pretty common, but often forgotten, lifestyle factors. So especially during the pandemic, this is like impossible. But it's important for all of us, especially kids with epilepsy, to get adequate sleep. Even if they don't have to get up for school at 8 a.m., going to bed at a reasonable time, turning the screens off before bed so they can fall asleep, and trying to keep a fairly decent schedule, even when there seems to be none, can help overall and hopefully decrease the incidence of breakthrough seizures and medication side effects. Avoiding seizure triggers if possible. So everybody has different seizure triggers. There are ones that are pretty common amongst everybody with epilepsy. Avoiding sleep deprivation if you can. If you're an adult, avoiding alcohol if that's a trigger for you. Making sure you get regular meals if that's a trigger for you to avoid in missing meals. So various things, avoid your triggers if you can. A second plug for encouraging your child or remembering yourself to take medications when they're prescribed. And if you end up missing a med, then either taking the next dose or talking to your neurologist or following the plan that you have for any missed medications. And it's also, as a parent or a provider, it's important to remember that as a child grows and develops, their needs will change. So if you have a 13-year-old who's had seizures since they were 5, and suddenly they don't want to go to bed at 7 anymore, it's probably because their body is changing. So you have to adapt to their change. Also, as they grow up and grow bigger, their medication doses might change. Or as they grow up and they grow bigger, specifically when kids go through puberty, their needs or their seizures or various things might change. In school, as their subject matters get harder, as their classes get longer, they also might need a little adjustment to their IEP or their 504 or to whatever help they have in school. And don't be discouraged if one thing that was working last year is not working this year. That's just how kids are. They tend to grow and they tend to change. And I think that's all I have. I'd be very happy to answer any questions or to discuss this more.
Thank you, Kristen. I'm going
Thank
to
you.
stop sharing my screen quick. So, while I get my screen back to normal, please go ahead and submit any questions that you have. There we go. Can you see me? I always have to ask because sometimes I feel like it lags a little bit.
Sure.
So yes, please use the Q&A button to ask your questions. You can also use the chat button if you would rather use it that way. John and I will both be looking at those. But Kristen, we know that sleep is very important. You talked about that quite a bit. What treatments for children, I guess, I guess I don't know if I want to ask in general, but we'll just talk about pediatrics. So could you talk about any treatments that you know of for that?
Yeah, absolutely. I'm doing a sleep fellowship right now, so I can go on for hours. All right, so if we're talking about sleep apnea, whether it's sleep apnea because your tonsils are big or your airway collapses, or sleep apnea because your brain forgets to tell your body to breathe, the gold standard treatment of that is sleep or CPAP. If you guys have heard of so it's when you actually put a mask on your face or under your nose, and it delivers air to the back of your airway to keep it open. So that's treatment number one, especially for adults. Also can be used in kids. And then if it's a child that has mild sleep apnea, actually sometimes taking their tonsils out can help a lot. There's interestingly an association with tonsil removal and improvement in like ADHD symptoms, because a lot of kids that look like they have ADHD are just sleeping poorly at night.
Gotcha.
So and then I could go on and on for hours for treatment of insomnia and other things, but that's kind of the top tier treatment for the thing we see most commonly.
Perfect. Yeah, I was curious about that. And I know the machine, I just wonder how children like to have that on their face, especially the really young ones. So I wonder how the success rate is with that. You know what I mean?
I do totally know what you mean. So for the really young ones, we try to avoid it because no one really loves that thing.
Yeah.
For older kids, and so actually the first thing we look at is if there's a tonsil or a nose thing we can fix. The older a child is, the better they can acclimate to it or kind of learn to tolerate the CPAP. Often it's one of those things, probably like epilepsy meds. You start taking them and it sucks, but then you get used to it and you feel a ton better. Most people that actually use CPAP after the first week or two, they feel so much better they wouldn't go back.
Yeah,
so they feel
just getting used to it. Okay, very interesting. So we do have a question. After medication, what are some of the best ways to support my child at home with cognitive skills or issues?
Good question. Do they have, so first of all, it sounds like you have an IEP or 504. At home, sometimes one-on-one instruction, like sitting with your child and walking them through tasks in a kind of breaking it down manner is helpful. Sometimes that's really overwhelming to the child because they've been at school all day, they're exhausted. So I honestly would start with giving them a snack, having a rest, and giving them a hug. After that, maybe depending on the age of your child, asking them to direct you. What is most hard for you right now? And taking that through just step by step. And then finally reaching out to your teacher and sending them an email and asking them to, kind of teach your child in the way that makes most sense to them, or even just do a Zoom call. There's a lot of that lately with the virtual learning. My kids have been logging on to ask their teachers questions. But honestly, I'd start with the common sense approach of telling them it's going to be okay and giving them a hug and reassuring them.
That's wonderful. That's really great. We have another question here. So how often do pediatricians get involved with children's teachers? And is that a good or bad idea?
That's a hard question. So you're speaking to a former pediatrician. I did that for 10 years. I tried not to directly get involved with the teachers because the teacher, they're trying their hardest with a whole bunch of students. So the first place to start would be if you have a legitimate concern about certainly ADHD or ADD or learning, bringing them to the pediatrician's office for evaluation is a really good place to start. The standardized forms that we use to diagnose ADHD actually also screen for cognitive disability, depression, and anxiety. So 3 of the things I talked to you about. So that would help ferret out what's what. After that, I have written a letter to the school to request an IEP, because depending on where you are in school, sometimes they'll push you off a little bit. It just depends on the school district. Beyond that, your provider emailing your teacher, I try to avoid that because I think then that would put you in between, you as a patient or as a parent. But you certainly can request a formal evaluation at the school. I think or you request that your pediatrician advocate for that, because that's a quick letter.
Okay,
Hopefully
that makes sense.
That question.
Yeah, thank you. Let's see, we have another one. What is a good way or a simple way to explain the difference between epilepsy and ADHD to my child's teachers?
Oh, good question. Okay. I'm just thinking out loud. So first of all, I would start with, they're not the same, but they're definitely related. And while epilepsy, like the most common thing we'd see is them having your child having a seizure. ADHD affects their entire life. So epilepsy can come and go. We need to treat the ADHD and help them focus and pay attention in the classroom. I'm not sure I am answering your question correctly. I'm thinking out loud.
That's okay.
So epilepsy affects the way a brain learns, and ADHD is one name for how it learns differently. Right. Maybe that's a more concise way to answer that.
Yeah, we can always refer them back to this video because you did touch on all of that too. So
there you go.
That's okay. Yes, thank you. I do have a question also. You talked a little bit about for ADD and ADHD, the stimulant and non-stimulant medication. Can you explain what that is a little bit?
Sure. So I said stimulant because a lot of people will come to me as a provider and be like, I do not want Adderall, or I do not want Ritalin. So stimulant classification are things that are, they're related in that they increase the epinephrine or the attention pain hormone in your body a little bit, and they help you focus on what's in front. Stimulants do come with side effects of appetite suppression and sometimes difficulty falling asleep. But if you dose the medication at the right time and you keep a low enough dose, then that shouldn't be a side effect. But that's one thing we'll follow really closely. The non-stimulant medications, clonidine, Strattera, and sometimes guanfacine work on different receptors in the brain. They work, they may make norepinephrine, which is something that helps us focus, but doesn't like laser focus, or sometimes serotonin more available in the brain. So these are all neurotransmitters. And so the ones that affect different hormones that are not the stimulants sometimes don't always work as well in all children, or sometimes we have to use a combination of the two.
Oh.
Did I answer that question?
Yes, thank you. Thank you. That's interesting.
Sure.
I think it was the same slide too. You talked about behavioral interventions. I don't think you talked about exactly what that is. Could you maybe explain that a little bit?
Totally.
Thank you.
I brushed over it because I haven't seen as much success with behavioral interventions. And it's particularly for kids with really kind of just mild ADHD or ADD. So the behavioral intervention is more teaching them to focus. Or for the kids the hyperactive kids that need to move, if you've been in the classroom and you've seen the kids with like the fidget or the squeezy ball or the chair where they can move, those are some behaviors you can do to get rid of the hyperactivity, which sometimes helps the kid focus.
Cool.
So it's more kind of along that kind of stuff.
Yeah. And I think that it's just that kind of stuff is more present too. Even when I was going to school, I don't think that's really any of that was around. So it's pretty interesting to have that. John, do you see any other questions at all? I don't see anything. Sorry, you're muted. All right, Kristen, anything else you want to add or anything before we end?
No, I don't think so. I powered through a bunch of slides. So if there are any questions, feel free to email me. I'm happy to answer them.
Thank you so much. Well, thank you, Kristen. We appreciate your knowledge and your time. Again, this is recorded. We'll have it up on the website that John typed in the chat by early next week, so you can refer back to that or refer someone else to it as well. So with that said, again, thank you so much. And I think we'll end the call tonight. Have a good night, everybody, and get out there and shovel. Just try to embrace the snow as much as possible. All right. Thank you. Have a good night.
You too. Good night.